Hello everyone and welcome to our webinar on wastewater drug testing. I'm Nathan Brown, the National Chief Scientist at Safework Health, and I'll be your moderator for today's session. We are thrilled to have Dr Phil Tynan here with us today, who will share his insights into this important topic. Before we get started, I do have a few housekeeping items we'll cover. Firstly, today's webinar is being recorded and the recording will be made available to all registered participants. Secondly, if you have any questions during the presentation, please type them in the questions area and we will address them during the Q&A session at the end. We'll also send you a copy of the Q&A via email. Now let's introduce our speaker. Dr Phil Tynan is a renowned toxicologist and retired clinical biochemist pathologist. As the National Toxicologist at Safework Health, Dr Tynan specialises in substance abuse testing, supports the development of new assays and procedures, and provides expert advice to clients. Thank you for joining us today, Dr Tynan. The floor is yours.
Okay, so what's all this fuss about drug testing? Why is it so important? Well, Australia basically has a high accident rate in comparison to our position in the OECD as the world's 13th rated economy. We in fact have an ongoing problem with drug use, primarily with amphetamine type stimulants, especially like methamphetamine, and to a lesser extent stimulants like cocaine. Now this table from the Australian Bureau of Statistics listing worker deaths YTD up to July of last year summarises workplace death rates by job category. As you can see, there's been an improvement in agriculture. And what's interesting is that this was aided by stringent workplace drug testing and ongoing fitness for work assessments in the industry. On the other hand, unfortunately, the accident rates are increasing for mining and construction. Now, all of this raises the question in this new slide is how important and how impactful are drugs? Well, this slide summarizes the relative accident risk rate of sedative drugs alone. As you can see, they're quite significant, and you should realize that these stimulant drugs, which are quite addictive, like methamphetamine, are far more impactful by about a factor of 2. Okay, so what is wastewater drug testing? How do we tackle this problem? Well, to tackle a problem, we need to know the size of a problem. And wastewater drug testing is the best way to generate a real-time snapshot of drug use at the workplace. Wastewater testing, which also used to be called grey water analysis, was originally used in the 1990s to monitor the environmental impact of liquid household waste. And a decade later, protocols were extended to study trends of illicit drug use. And since then, wastewater analysis has been adapted to estimate illicit drug consumption, either at specific target sites like the workplace, or expanded to include entire geographic areas, as for example, the nation as a whole. So, as you can see in this slide with the ASIC National Wastewater Drug Monitoring Program, it is relevant to Australia because in June 2016, Michael Keenan, the then Minister of Justice, allocated $3.6 million to develop a national wastewater drug monitoring program, which aimed to assay a representative sample of Australia's wastewater from the various urban and rural communities. Now, the initial scheme was so successful that it's become a standard feature of national drug surveys. We now have 3 reports done on average every year, covering between 50 to 60% of our population with each report. Okay, so the latest drug report has been released this month. This is the 22nd report. It was released on the 11th of July. And it examines drug use over the period from December 2023 to February 2024. What it does is it covers about 55% of the Australian population, and this is 14.1 million people on average. Now, this next slide, the findings are summarized, and they're rather disturbing. What they've reported is that there are historical, in other words, never before recorded highs in capital and regional cocaine use, as well as capital/urban methamphetamine use. On the basis of population weighted average, there's been a drop in oxycodone use, but there's been a substantial rise in methamphetamine, in cocaine, in MDMA or ecstasy, and ketamine use at all sites. And when we have a look at Australia compared to our international peers in the Sewage Core Group Europe study, which is basically an international collaboration that covers Europe, Asia, the Americas, and Oceania, Australia, unfortunately, has the second highest recorded meth consumption rate per capita of all 30 participating nations. And quite concerning, we are 20th out of 32 nations in terms of cocaine use per capita, despite the fact we neither manufacture cocaine nor are we near to any local cocaine supplying sites. Okay, so let's go to this next slide. The National Wastewater Drug Monitoring Program provides reports on the total drug load per population, which they then convert with an algorithm to the numbers of standard doses per population. And this gives us a practical handle on per capita drug use. As you can see in this next slide, they also can give you a graphical demonstration, a graphical synopsis of the findings. These are less useful than the bar graphs, which we tend to emphasize. So how's this actually done? How do we perform wastewater testing? Basically, wastewater testing involves sampling a source of wastewater effluent and estimating the quantity of drugs consumed by a defined community by measuring the levels of illicit drugs and their metabolites that are excreted in urine and feces into the wastewater. So it's done through a three-step process. First step is collection and subsequent analysis of the sample in the laboratory. What we then had to do is we then have to get the data on the physical and demographic size of the wastewater stream and the population. So we should have the flow rate. This isn't critical, can be compensated for, but it's very helpful and makes it more accurate. But above all, we need the actual population numbers of the people who are being captured by that particular area. In other words, we're basing it on the belief that everyone has to go to the toilet at least once a day. So we need to know what the population at that particular work site or that subset of the work site is. Even in cases where you don't have any flow data, for example, portaloos, you can still do the calculations. The figures are less accurate, less precise, but so long as you know the population, you can work out per capita usage rates. And the final stage involves applying a back calculation factor, which enables us to work out the average use per capita and the number of standard doses of a particular drug per head of population. Okay, so what are the limits of wastewater drug testing? What can it not do? Well, first off, wastewater drug testing is not a replacement for random drug testing. It's an adjunct to standard workplace testing. It offers a valuable complementary data source for monitoring the quantities of illicit drugs that are used at a population level, but it can't tell you who the actual individual users are. It can't provide information on the prevalence and frequency of individual use. In other words, it can't differentiate between a large number of people taking small doses or a small number of people taking large doses. It also can't differentiate on the basis of the purity of the drugs consumed. So what we do to work around this is relatively simple. We rely on two things. First off, with respect to prevalence, we can calculate what the minimum number of drug users could be for the amount of drugs were detected. And we do this by saying, well, we know what the maximum dose is that a person could take of a particular drug without collapsing. And so if you then divide the total amount of drugs that you found and the population number, you can then work out what the minimum number of potential users is. because if there were fewer users, they'll have to take higher dose and they'll collapse. The other thing that we can do to address the issue of purity of drugs is to look at the police and border capture data, which they tell us each year about the purity of the drugs that they are capturing, that they are confiscating. And you can factor this in. And what we do is we also give you the so-called street dose, which is basically the number of doses of a particular drug based on the purity of what the police are capturing. Obviously, this is relatively crude. It's only done each year, so the data may not be exact, but it gives you a rough idea what the intake is like. Okay, we've done the limitations. What are the other issues? Cannabis is an issue. THC, which is the tetrahydrocannabinol, it's a major metabolite of cannabis, is a very sticky molecule. And as a result, it gets absorbed to varying degrees on the surfaces of plumbing and tankages. Now, if you're dealing with a large number of wastewater flows all being combined, if you're dealing with lots and lots of plumbing, lots of piping to direct your sewage, as for example in the suburb of a city or even something as large as a whole township, then it's not a problem because you can generate a rough average figure. This is the law of large numbers, so you can smooth out the figure. However, if you're testing on a workplace basis, there is a very large variation in the rate of adsorption and hence the rate of capture of THC in the sample. In other words, you don't know how much of the actual amount that was originally excreted you're actually picking up. And so as a consequence, we don't include THC in our workplace drug testing analyses. Okay, so what are the advantages of the methodological advantages of wastewater drug testing? Well, the method is non-invasive, okay? And it's done on a population scale basis. So individuals are not targeted and it's not subject to privacy restrictions. Unlike surveys and questionnaires, it's not subject to response and non-response bias, so you can't fake it. And it can better identify what drugs are actually being taken by a population as opposed to what they're actually buying, because they know what they think they're being given, but they have no idea what the seller has actually given them. It also has the potential to provide timely, in other words, real-time information in short time frames on geographic and temporal trends, what kind of changes you're getting in usage. This brings us to the major advantage. It could potentially be used as an outcome measurement tool to gauge the effectiveness of workplace drug use intervention strategies. And you do this by basically following an iterated strategy where you sample, you introduce your workplace drug reduction use program, and then you sample again sometime later, 3 months, 6 months, 12 months later, and you see whether you've been effective. And finally, it enables us to detect fluctuations in weekly patterns of drug use. In other words, when should we focus our random testing? For example, 3/4 of urban sites show higher cocaine and ecstasy use the day before and during weekends and public holidays. Whereas amphetamine and methamphetamine usage tends to be relatively flat across the week. So that way you can see what times you should set your random testing for. Okay, now this raises the question, what drugs can you test for? Well, these include amphetamine type stimulants like amphetamine or speed, methamphetamine, ice, MDMA, which is ecstasy, and MDA. It includes cocaine as well. We test for the standard opiates, which include codeine and morphine and derived from that heroin level. The National Wastewater Drug Monitoring Program doesn't, because they have a problem, because they are dealing with such large populations. There are going to be major inputs from medical sites, hospitals, other facilities which are going to basically obfuscate the level of codeine and morphine use, so you won't know what's licit and what isn't. And they only give you a rough estimate of the heroin level. We can also test for fentanyl and oxycodone, which they do test for in the National Wastewater Drug Monitoring Program. And finally, we also test for benzodiazepines, which are important, as I'll show you later. Okay. What do we find when we start testing? Well, some other interesting things. There's what's called the amphetamine paradox. In all the National Wastewater Drug Monitoring Program reports, and also in lots of reports from overseas, it's been noted that amphetamine per capita strongly correlates with the meth use rate. In fact, in Australia, you have roughly 7 times as much meth as amphetamine found in the community wastewater, correlation factor of about 0.77. And this is consistent with the known fact that amphetamine is a breakdown product of methamphetamine. And in fact, it was first reported by Garcia Law et al. In 2016. And they said from this, we could deduce that on a large scale basis in Australia, we have a big meth use problem and negligible levels of amphetamine usage. However, workplace studies, both in Australia and New Zealand, in Europe, America, in Japan and China and Southeast Asia, what they've found is while in many sites this also holds true, even when you're correcting for average regional dexamphetamine use, there are going to be workplaces and work sites where there is no correlation between amphetamine level and methamphetamine level. You may not even detect methamphetamine in some sites. Well, and this is basically an anti-correlation. In other words, in some sites, primarily those where you've got significant disposable income, like mining and engineering sites, for example, there's a higher tendency for independent amphetamine use of speed, independent of meth use. This was first worked out by Stoops and Craig in 2013. And their explanation is as we learn more and more about the undesirable effects of meth, people are transiting to what they perceive as a safer alternative, which would include speed, amphetamine, and to an extent, cocaine. Okay, now let's have a look at morphine and heroin use. A fraction of ingesting codeine is converted by the body to morphine. So by working out the morphine to codeine levels, we can basically work out when we've got independent morphine use and when we've got simply a reflection of codeine use. Codeine use is quite high, legitimately in the population. Morphine use isn't or shouldn't be. So whenever the morphine level, the morphine ratio to codeine is over 1, you know that there's primarily morphine use. Or there is use of a derivative of morphine, heroin. Heroin, after all, is diacetyl morphine. The great advantage here is that codeine and morphine are excreted for quite a while after the heroin's been used, so we can quite accurately track people if they're heroin users. And what you do, if you're dealing with small populations, is you can exclude known medical use by checking on the reported levels from the medical centers and the hospitals, the known prescription rate for the region, and the prescription rate for the state where a lot of the fly in, fly out workers will be coming from. And you can correct for that. So you can exactly work out whether you've got excessive use of diverted codeine, whether you've got use of morphine, or more likely you've got a problem with heroin. Okay, and that brings us on to benzodiazepines. Benzos are a major class of prescription drugs, in fact, the major class of prescription drugs that are associated with workplace accidents. In fact, they increase the workplace accident frequency by about 117 to 230% when they're used according to the prescription. Okay, not some other way, not in excessive level, but according to the prescription. And the impact, in other words, is roughly equivalent to a blood alcohol of roughly 0.05. Now, Although there are numerous benzodiazepines that people can take, we're lucky in that a lot of them all converge onto a common breakdown product called oxazepam. So by measuring oxazepam, we can basically work out what the site-specific benzodiazepine use rate is. And because these drugs are monitored closely, we can say, well, look, it's appropriate for your population or you've got a problem. So what are the methodological advantages in this next slide? The advantage is that we're dealing with a comparator, which is a national wastewater drug monitoring program, which guides us into what other drugs we want to look at. And one of the new drugs of concern that we're going to be focusing on at Safework is ketamine. Ketamine's a legitimate, it's legal, dissociative anesthetic, but it is addictive and it is, if not used for medical reasons, quite dangerous. Since October 2021, the National Wastewater Drug Monitoring Program has been testing for it. And what they've found, very disturbingly, is the levels of use have been monotonically increasing report by report by report. The highest levels are in the capital cities and urban areas, and Victoria and Northern Territory have the highest per capita consumption. Although if you look at that graph there, which is a recent National Wastewater Drug Monitoring report, you'll see that some regional areas, for example, in New South Wales, you have very high levels as well. And this is why we're going to be introducing it. And it's a drug that you should start testing. Okay, so what are the reasons you'd actually do a wastewater drug study? Again, the methodological advantages, as we've stated, you're able to compare what's happening at your site with other peer sites and with the picture of drug use in the nation as a whole. So in this next slide, we go through the basic reasons why a person would perform wastewater drug testing. And there are 5 reasons. The first is fact-finding, to determine what the true drug use rate at the work site is, obviously. To determine how effective your workplace random drug testing program is at capturing drug use. To get a real-time snapshot of drug use at the site. To use it as a response to increased rates of accidents or near-miss events at a site, or high rates of drug detection in the standard random drug testing program. And finally, most importantly, to determine how effective a drug use reduction program at your site has been. Okay, let's go to this next slide. This is the important one. Basically, the great advantage of wastewater drug testing is that it can function as a real-time assessment tool. By iterating the process, in other words, by doing a wastewater drug collection, getting a report from us, modifying or adopting your drug intervention strategy, you can then, after 3 months, 6 months, 12 months, whatever you decide is appropriate, retest and see, has your intervention strategy been effective? Because you may not be picking it up all that accurately with random drug testing. You certainly need random drug testing and more of it, but there's no way random drug testing will capture everyone. If you've got a canny workplace, a canny workforce, they will know how to escape this. So let's have a look at some actual clinical cases. There are 2 cases I want to show you. This first one is a large mining site. It's been de-identified. Okay, and the dates have actually been somewhat changed. The first thing to note is that codeine, light blue, dominates the picture. However, actually, if you compare the codeine level at this site with peer site usage and regional prescription rates for codeine, you'll actually find that the usage is pretty much par for the course. Remember that these are standard doses and that no one just takes 1 codeine tablet a day, or very rarely, 1 low-dose codeine tablet a day. So you effectively can divide the numbers by 4 or 8 to get the actual number of people taking it per 1,000 people a day. So it's not quite as horrific as it looks. Okay, let's go to this next slide and get rid of the codeine. Let's remove it. This is the same data without the codeine. What have we found? Well, we've got high amphetamine use independent of methamphetamine. The level of use was substantially greater than the dexamphetamine script rate, both for the job category and the region and the state, nor, interestingly enough, does it correlate with methamphetamine use. Apropos methamphetamine, it peaked at 8.5 standard doses per 1,000 workers per day, which is actually substantially higher than the actual capture rate from the admittedly rather sparse random testing program that they had performed at the site till then. Cocaine use, interestingly enough, occurred on 4 of the 5 days when methamphetamine use was observed and showed a high correlation in pattern. In other words, peak meth occurred at the same time as you got peak cocaine use, oddly enough. Oxycodone use was substantially above the work category and the original script rate, although there were no known declarations of oxycodone use at the site. Interestingly, if you have a look at what we'll call the 30th of September, you've got a marked peak of benzodiazepines, of oxazepam, the dark blue. This is actually a known phenomenon because it represents the end of a 7-day shift. And it's been observed in many work sites here and overseas that when you're going from a shift back to normal life, quite a few people will take benzos to reset the clock. So this was expected. And in fact, it was the level of usage was standard per population and per drug category. Okay, let's have a look at the next slide. What happened was the site initiated a widespread workplace drug reduction use program, and they're focused on systematic and more frequent random drug testing. They had started to use more urine. They were predominantly and still remain predominantly oral fluid, but they adopted a flexible strategy where required. Importantly, they also recruited workers by educating them and introducing a worker education program on the risks of drugs, stimulant drugs in this case. So the site was retested about 5 months later. Again, we had the dominance of codeine. Again, the level was predicted from work site and in fact was to be expected. So let's get rid of the codeine and have a look at this new slide. What we see here is interesting. We've had a very marked reduction in overall stimulant use. Methamphetamine use had now peaks at 1.5 standard doses per 1,000 people per day, as opposed to 8.5 previously. There's no cocaine use at all, and amphetamine use had been markedly reduced. Unfortunately, oxycodone use rates had not dropped, and that's because no effort had been made to focus on oxycodone. And what, in fact, the site then decided to do was we expanded the program, and I gave them some stuff on oxycodone use risks when it's not for legitimate medical purposes. And in fact, in later studies, they found a reduction there as well. Okay, let's get to the next case. This one is another site, and this is where we're following an intervention program over a period of about 9 to 10 months with 3 separate wastewater collections. Each collection, which is each level, was performed for a period of about 7 days. So these are the weekly average levels. This first slide deals with stimulants, primarily methamphetamine, amphetamine, ecstasy, cocaine. The first testing on month 0 was found to have a significant methamphetamine and independent amphetamine use problem. Okay, the use rates did not correlate. And as a result of this, there's also a significant cocaine use problem, as you can see as well. As a result of this, the workplace decided to implement a drug use reduction program. In this case, it was a top-down reduction program, and there was very little effort made to recruit worker support. So there's no education to speak of. They continued their intermittent random drug testing, but it was patchy. And unfortunately, it was predictable. Thursdays was drug testing days, guys. And they might occasionally do it on Tuesday as well, but everyone knew be a good boy on Thursday. Have a look at the next slide. This is for sedatives. The level of codeine, again, corrected, as we said before, for site and job category, and the actual dose that a person would normally take of codeine per day, it's within the acceptable and predicted range. Was not predicted was the oxycodone level, which is again high. There were no declarations at site, and locally there was very little use of oxycodone. Oxazepam use was standard per work category and site. Now let's go back to the earlier slide. This will show what's happened when they intervened. What's interesting is their initial intervention, as I said, was patchy, it was inefficient, and what they observed was a substantial rise in methamphetamine use rates, and in fact, statistically speaking, there was no significant difference in the rate of amphetamine use, and cocaine use was stable. Okay, well, that was a problem, so they had a chat with us what to do. What we decided was to focus on, again, recruiting worker support with education program, to upgrade the random drug testing. This time, don't do it the same time, same day every week, okay? Make it truly random. And occasionally switch to using urine. Again, however, they were mostly oral fluid in this case. And what we found was, interestingly enough, when they retested 6 months later, there was a substantial drop in usage rates. The methamphetamine use rate had dropped by a factor of 3.8 to 3.9 fold. Amphetamine use was negligible, and there was no cocaine use detected at all. As you can see in the next slide, we also had the same effect with the oxycodone. We had gotten rid of that. So that shows that if you do adapt your program, you can in real time ensure a successful intervention. Okay, well, let's have a look at this slide here, basically to sum it up. The important points are that wastewater testing provides a real-time picture of the actual level and breakdown of drug use at a workplace. It allows our clients to design their drug and alcohol testing program for maximum effectiveness. It's without doubt the most reliable and the quickest method to assess the effectiveness of drug use reduction programs, and it allows direct comparison with national and regional drug use trends. And this is important because if your work site actually follows regional trends and they're reporting a rising level of, let's say, ketamine use, you can make a reasonable guess that's probably going to impact you as well. Okay, guys, questions?
Thank you very much for that, Phil. That was great. We'll now move on to the Q&A session. We haven't received any questions at the moment, so if anybody has any questions, please pop them up in the question section and we'll go through those. In the meantime, Phil, I guess I'd ask you, if you're establishing a program like this, how often would you recommend testing across a population in terms of, sampling per day, sampling per shift?
Okay. Basically, random drug testing, ideally with your workplace population, you should ensure that everyone in your workplace is tested. Ideally, it would be at least twice per year. Okay, so you have to factor in the frequency of testing depending on the number of people at the workplace. In practicality, it's usually to ensure that it's once per year. Now, there was a study done last decade in Portugal, primarily with the railway services, not just the train drivers and the staff on the trains, but also those at the train stations. They had a drug use problem, and they found that you got an optimum level of detection or capture of drug use when the frequency of testing was at least once per year across the board, up to 1.5 times per year. Everyone has 1.5 chances of being tested sometime during the year, and especially when it was fully random. So long as the staff knew that there was a reasonable probability they could get caught, this had an impact. Levels above twice per year don't appear per person, don't appear to have any further impact. So ideally, somewhere between 1 to 2 times per year per head of your worker population.
Excellent. Excellent. Thank you very much. Somebody has asked, is there any data for New Zealand, Phil? Do they do any wastewater testing?
There's some data in New Zealand. They do far less than we do. And if any New Zealand people want to send us samples, we're happy to analyze them, and I will compare them to New Zealand figures. Unfortunately, New Zealand doesn't have a fully integrated testing system as we do. So it's going to be based largely on your nearest big city.
Excellent.
The advantage in Australia is that, for example, if you're in the Pilbara, we are doing wastewater testing, national wastewater drug testing in the Pilbara, and I can say you are representative or not of the regional use rate in the Pilbara.
Excellent. And somebody has asked if Safework is now able to screen for ketamine and other drugs if they're requested. So,
well, we are basically offering ketamine later on this year as part of our testing program. And I would certainly recommend later this year for people to consider basically adding it both to their wastewater requirements and also using it in their random drug testing. We do have cups which can detect ketamine, and as I said, we'll be making those available.
Excellent. And then one more question. Is there any other novel psychoactive substance screening being done?
They're the exotic opiates like buprenorphine and some of the nitazene compounds, which we are considering in the future looking at. The issue at the moment, though, is that there are no standard cups which pick up stuff like nitazene properly, unfortunately. Hopefully, though, by next year, there should be some products become available in the market. When they do, we'll certainly inform our clients. Why are we not suggesting using the synthetic cannabinoids? Well, basically, they used to be done. And the problem with synthetic cannabinoids is that they change from year to year, and the market's effectively collapsed. Very, very few people are using the synthetic cannabinoids anymore. Apropos bath salts and the rest, I would still suggest occasionally doing your random testing for bath salts. It's unfortunately not possible to do that in wastewater because we can't correlate how much of a dose that the person takes of, for example, Enbomi, for example, will actually come out in the wastewater. So we really don't know what fraction we're capturing. And so that's a problem. However, intermittent testing for, Enbomi and the rest in RBT samples is probably not unreasonable.
We've also had a couple of questions about fentanyl. So is there any fentanyl screening being done? And have we seen an increase in fentanyl use in Australia?
Fentanyl levels fluctuate very markedly, more than oxycodone. Oxycodone's been included, as you all know, in the recent Australian standards. In the 2019 oral fluid standard, for example, it was included. And the reason for that is that there is substantial rise in oxycodone use. Fentanyl use is occurring, but interestingly enough, it's intermittent and spotty. The problem with oxycodone and fentanyl is that the products are diverted medical supplies, and as a consequence, access to them may not be, shall we say, as guaranteed as methamphetamine, which, for example, is frequently made in meth kitchens in Australia. And it's also one of the ones that are difficult to predict. What we've found is with fentanyl, there's oddly enough a correlation with contractors. In many of the larger sites, it was found that when they have contractors or lots of people from other sites coming in, that's when the fentanyl would be introduced. So yes, fentanyl levels are increasing.
Excellent. Does anybody else have any other questions? It doesn't appear like it. So I will say thank you very much to Dr. Tynan for your insightful presentation and for answering our questions. I would also like to thank our audience for their participation and engagement. Before we close, I'll remind everybody that the presentation will be made available as a recording to you shortly, and you'll receive an email with the link. Plus, we'll also send you a copy of the Q&A via email in a few days. If you have any further questions or need more information, please feel free to contact us. Thank you all for joining us today and have a great day. Thank you, Phil.
Bye, guys.